Welcome to the Clinical Athlete Journal Club meeting number 12. My name is Quinn Hennick, and I'm a proud clinical athlete provider, and I'm joined by Kevin McNamara, who is a physical therapist currently completing a residency at Johns Hopkins. He's a longtime forum member and the one responsible for bringing the Clinical Athlete Journal Club to life. So thanks for being here as always, Kevin.
Yeah, absolutely, Quinn. I'm excited for this one. We got a full house.
We do. We have a lot of people, and it's going to be good. I think we're going to get some really good questions because this is a topic that we probably all deal with. Speaking of, the journal club topic is exercise training for chronic low back pain. What's most effective? And we have a specific paper that we're going to be going off of a recent review. I've made a couple poll questions to get a feel for the crowd that we're working with, or actually just one poll question this time. So I just launched it. It should have popped up right in front of you. Just interested in the demographic at our meeting here. So are you a clinician? Are you a coach trainer? Are you a student clinician, student coach trainer? Let us know. Give you a few seconds here. Looks like we've got almost a 50-50 split. Oh, okay, there we go. 47% clinician, 41% student clinician, 9% coach trainer, 3% student coach trainer. So mostly clinicians or student clinicians in the house, a few coaches and trainers, which, you know, we talk about low back pain. Whether you're directly dealing with that or not as a coach or a trainer, I'm sure that you've had clients and athletes who have come up to you with these types of complaints. So relevant to everyone, I think. So I'm just going to jump into the paper here because there's a lot to discuss. And again, if you have questions or if you want to chime in, use your control panel and we'll get you in here. So the name of the paper here is, by the way, Kevin, am I sharing my screen or you just see my face?
I still got the poll question up.
Oh, good. I'm glad I asked. All right.
There's that beautiful face.
Okay. Well, last time I was sharing my screen for half the meeting. You remember that? Okay. The paper is, which specific modes of exercise training are most effective for treating low back pain? A network meta-analysis. The lead author here is Patrick Owen, and this is a recently published article. This in October, I think this came out. And the aim of this paper was to examine the effectiveness of various modes of exercise training, specifically in non-specific chronic low back pain. So, you know, they make a note that about 20% of cases of low back pain is this chronic non-specific, but this subset equates to 80% of the cost that's associated with the care of low back pain. And so non-specific, you know, they define as not having a distinct mechanism to the pain. The clinician is unable to identify a specific structural mechanism or something in their history to be able to diagnose a specific tissue or implicate some type of structural abnormality, something like that. And so the umbrella term of exclusion is non-specific low back pain, and the chronic part of the descriptor is having the pain lasting longer than 12 weeks. So anything over 12 weeks, it was accepted into this definition of chronic low back pain. So there's always limitations when we're talking about these types of terms and descriptors, but that's what they were going off of. So there were 89 studies total in this paper where they're looking at various interventions for low back pain, various exercise interventions, resistance training, motor control, neuromuscular exercises, Pilates, yoga, aerobic exercise, aquatherapy, stretching. What I miss? McKenzie exercise. And then they were comparing that to no treatment, comparing that to clinician hands-on treatment, so manual therapy, and clinician no hands-on treatment, so like general practitioner recommendations or education. And so this is a meta-analysis. So they're aggregating a bunch of different studies on the topic, and they were all randomized controlled trials of varying quality. So that's what we're looking at, and then they're comparing these interventions with themselves, and they're comparing these interventions to no treatment, exercise therapy to non-exercise therapy, and seeing what we got. And what was interesting, and I'll just kind of give a general synopsis of things. Well, actually, I wanted to make a note of the samples in these studies. Sometimes you get meta-analyses that are just, they're a victim of the studies that are part of the meta-analyses. So if the studies that you're including in your review or your meta-analysis are very different from one another, then you get results that are hard to pin down to any one population or to make real definitive claims. But it also is more like it is in the real world. So what we have in this study, in this meta-analysis here, is we've got a bunch of studies with vastly different samples. So the sample sizes in some of these studies were anywhere from 20 to 240 people. The age ranges were anywhere from 20 years old to 70. The study duration, anywhere from 4 to 24 weeks. Average duration of pain, how chronic the pain was in the samples here, anywhere from a quarter of a year, a couple months or a few months, that was their limit, anywhere from 12 weeks to 14 years. So imagine the difference between those types of people that you're dealing with. Average pain intensity on a 0 to 100 scale of 21 to 79 out of 100. So, 2 out of 10, 7 out of 10, almost 8 out of 10. And then the frequency of the exercise interventions, anywhere from 1 time a week to 7 days a week. So all of these studies were aggregated into this meta-analysis. So just keep that in mind, when we're looking at the results, and we're going to talk about the things that we're going to talk about, which is there's not a ton of certainty here. Well, that's why, but that is more reflective of the real world. If you go to 10 different physical therapy clinics, you're going to get, and let's say all 10 of them do an active treatment of some sort, you might get 5, 6, 7, 8 different types of active treatment. Maybe, who knows, maybe 10, maybe all of them are just different. So you just keep that in mind. Essentially what they found, and there are some, I guess, more specifics here, but essentially what they found for pain, physical function, subjective, so is pain, subjective reports of physical function, mental health. These are some of the outcomes they're looking at. Active therapies such as Pilates, resistance training, aerobic exercise, motor control or neuromuscular type exercises. These things seemed to be effective on average for non-specific chronic low back pain to varying degrees. Where there was some divergence was that it seemed that active interventions were more effective than no intervention, which no intervention seemed to be the least effective thing. So in your head, you could be like, well, no shit. But when you think about other cases like acute low back pain, therapy and no intervention, not much different. But perhaps in this subset of people, non-specific chronic low back pain, doing something is better than doing nothing. And that something seems like if it has an independent active component, like some type of exercise component, that seems to be more effective than a non-exercise thing. So all of those different types of exercise interventions that I listed seem to be more effective than therapist hands-on treatment like manual therapy techniques. They didn't, again, if you're looking at the specific techniques, you go into the supplemental paper and read up on that. Exercise interventions also seemed to be more effective than therapist non-manual treatments or non-hands-on treatments, like just education, for example. So not only does doing something seem to be better than doing nothing, but that something seems to be more effective if it has an exercise component with it. And I'll go ahead and stop there as just kind of a synopsis of things. But Kevin, what were your thoughts on the paper in general?
Yeah, I thought it was actually a pretty timely paper. I actually had an evaluation this morning with someone that had been dealing with back pain since 1994. So this thing came right up to my mind. It's like, oh, you've been dealing with back pain since damn near I was born. Let me talk to you about the science of pain, right?
There you go.
No, I think to me, this was a big win for aerobic exercise, actually. If you kind of look across the board at sucra values, aerobic exercise was performing really well in pretty much every marker that they looked at. I think if we looked at mental health, let's see here, for pain, at a sucra percentage of 80, which was number 2. For physical function, aerobic exercise came in at 60, which was in the top 4. For mental health, it came in at an 80, which was tied for first. And then muscle strength, obviously you wouldn't expect aerobic exercise to perform too well there. Didn't really register. But to me, I think it just speaks to kind of the value of even something with just a general walking program for someone with chronic pain. And I think I'm definitely guilty because it doesn't exactly align with my bias, but I think that I definitely undervalue that to a certain degree. But more than anything, just kind of looking across the board at, there's just so much stuff out here that we're trying to throw at this. And, we talk a lot about a constraints-led approach to rehab and coaching on here, and for good reason, I think. But when it comes to chronic pain, I really just feel like identifying the constraints of the individual that need to be addressed is just really difficult. And if we can't identify those constraints, I don't really know how you can build, let alone implement, a plan of care that's going to be effective. So in many ways, I think we're kind of playing from behind from the get-go when it comes to this. And I think that's the real difficulty, is just trying to understand, what does this person need? And even more so, what are they going to respond well to?
Do you also see the results though? Because they have kind of their top 3 for each, for pain, for subjective physical function, for mental health. But it did seem like pretty much all exercise interventions, other than stretching and McKenzie, seemed like it had a positive effect. I mean, we could look at that, and we're talking about averages here. In this case, we whittle it down to the individual, and the conversation changes based on what they care about and what their goals are. But you could look at this as a refreshing thing, in that just get them doing something novel potentially, or something that they care a little bit about, or something they enjoy doing, or makes them feel kind of nice. And that can kind of change things up, because let's go back to the aerobic thing. Obviously, aerobic exercise can change physiology. How much of it, for the patient that you just discussed, having pain since 1994, if you get them on an aerobic exercise and it has an effect, how much of that is because of the physiology change in regards to their pain experience, and how much of it is just, oh, I can be a human again, and kind of reframing things. But you could look at it as, well, hell, if everything works, then nothing works. If everything matters, then nothing matters. And you can also look at it as, well, maybe the pressure is not, we don't have that much pressure on us to find the right exercise program. It's just, let's start with something, and that's probably going to push the needle forward, and we can kind of fine tune from there.
Yeah, 100%. I think that's the other way that you can kind of look at this. It's another note that I had here, is just find something to kind of get the person moving, right? Maybe address any unhelpful beliefs if they're there and they need to be addressed. But more than anything, it seems like it's a win for just movement in general.